Good morning, and thank you for the invitation to speak about active surveillance for small renal masses. I'm Tony Finelli from the Princess Margaret Cancer Centre, University of Toronto in Canada. I have no disclosures regarding this topic. To clarify, active surveillance is different than watchful waiting. Active surveillance, as many of you know, is a strategy to monitor patients closely who have a disease that can be cured, but only intervene when treatment is necessary. Watchful waiting, on the other hand, is an expectant management strategy that is really one to manage symptoms if and when progression occurs. In particular, in kidney cancer, this is different than prostate cancer, for which we have a longer experience and can salvage people with hormonal therapy for many years, and having a number of them succumb to something other than prostate cancer. We've learned over time, particularly from expectant management, that small kidney tumors grow slowly. The mean tumor size from this older study, which we are now approaching more than 15 years of data on, was 2.6 centimeters, and we've learned that over time, the average solid renal mass grows at about 0.28 centimeters per year. In a review of all of the series published, again, what we learned, particularly in the CT1 or less than 4 centimeter tumors, is that it was roughly 0.22 centimeters per year, but there was a real and measurable metastatic risk of 1 to 6%. Our Canadian national study across multi-centers led by Michael Jewett many years ago was published, and this was prospective, and some of the tumors were biopsied and others weren't. And what we see here is that regardless of a benign or malignant histology, growth rates can be very similar. Another very informative experience has been the DISCERN registry from Johns Hopkins. And through their publications, again, we've learned that surveillance is safe. And in this study, in which perhaps the patients are not matched perfectly, we did see that patients who cross over have a very high salvage rate, and that the overall survival and cancer-specific survival rates are quite similar, excellent, and acceptable. In a follow-up study of 600 patients from DISCERN, where again they looked at treatment indicated by greater than 4 centimeters or greater than 0.5 centimeter growth per year, we see again excellent results with no difference in cancer-specific survival at 7 years between primary treatment and surveillance, and obviously some selection bias. Overall survival was higher in patients with primary intervention, and again this is likely related to host factors. One other large series that deserves attention is from the Fox Chase group. And here you can see again that for localized renal masses with greater than 5 year clinical outcomes, intervention rates approach 42% at 5 years. And this is something to appreciate and share with your patients in the decision-making process. So when we look at all small enhancing renal tumors, the proportion of benign tumors, malignant, and based on grade, you can see that the small tumors are particularly more likely to be indolent. 80 to 90% of masses less than 4 centimeters are indolent, depending on your definition. And in America, we know that many of these patients are treated. From earlier surgical studies, we also learned that the very small tumors, again, are often benign, or those that are clear cell are often more homogeneous and of low grade. And although stage is a greater risk factor and size for progression of kidney cancer, grade is relevant. Kidney cancer, however, is a heterogeneous disease. And although the small renal mass refers to enhancing solid tumors less than 3 or 4 centimeters, we know that biologically and histologically, these vary greatly in their behavior. And in my opinion, which others may or may not share, that we cannot uncouple small renal mass biopsy from active surveillance. In cases of watchful waiting, however, the biopsy may be spared. This is our large experience of more than 10 years with biopsying small renal masses. And what we learned is that you can achieve excellent rates and that there are a variety of histologies appreciated with biopsy that can drive management. In a systematic review and meta-analysis of the diagnostic accuracy of small renal mass biopsy, we see that the diagnostic rate exceeds 90%, excellent sensitivity and specificity. Grade concordance is less robust, but if you break it down or dichotomize it as Fuhrman grade 1, 2 versus 3, 4, it's acceptable. If you don't use biopsy, then you can rely on some nomograms or some predictive models as to how likely something is malignant and or aggressive. And what we do know is that it increases with tumor size and male gender. The separation here is real, but again, very difficult to utilize in a clinic because it's not all or none, or in my opinion, less directive than the histology that can drive care. And again, a multiple studies reviewed here showed that male sex predicts malignancy. If you do know the histology, you learn a great deal. And we benefited from our center where we adopted biopsy very early as a routine practice for small renal masses. And we've been able to see that renal neoplasm with oncocytic features, either oncocytoma or chromophobe, grow very similarly and with excellent results. There was excellent concordance. The experience has grown now. And again, we're very blessed with excellent pathologists such that any tumor we've removed that's grown that was oncocytoma was also oncocytoma on final pathology. Because of our motivation to distinguish tumors based on histology and biopsy the renal masses and manage them accordingly, we were able to publish an experience of histology-specific growth rates to inform practice. What we learned early was that the papillary type 1 tumor grows much more slowly than clear cell renal cell carcinoma. As you can see here, on average, it's about 1 millimeter a year. And across the different pathologies, you can see varied growth rates. So the real risk of surveillance is metastases. Local growth can be an issue, but is less relevant than metastatic risk. So what is the metastatic risk of a small renal mass? We have to look at the data very carefully. This is for incident tumor size, and you can see here that some very small tumors do present with metastasis in about the 3% range. So it's important to stage your patient up front because they may already harbor metastatic disease. We are also learning a great deal through the TRACER-X work from Samra Tajurlik, and this goes beyond histology. This is looking at mutational drivers. And I put this study in for reference because when you look at the very small tumors, you can see that the clonal evolution is singular. And actually, the driver mutations are very low here and often single, speaking to a less aggressive biology. So what do we know about risk of metastases? In this older study, but an excellent review, where all patients who developed metastases with expectant management, we learned that size and growth were very important. Also, the metastatic events were almost always in clear cell renal cell carcinoma. So 23% of the masses followed exhibited zero net growth under surveillance, and none of them metastasized. The initial tumor diameters, when you compared the groups of metastatic to non-metastatic, were often larger, 4.1 versus 2.3 centimeters, and the linear growth rate was 0.8 versus 0.3 centimeters per year. Therefore, consecutive positive growth periods should be respected. This slide is courtesy of Phil Purazio. And what he shows here is that the number of positive growth periods was positively correlated with unfavorable pathology. Also, if you follow your patients closely with a clear strategy, over time you will have removed the growers and you'll have a population that are very well served by surveillance. So the guidelines have evolved, and this was our ASCO guideline that I had the privilege of chairing, and it was striking to me that from former guidelines, particularly those in North America, which advocated for almost treatment and only surveillance in the setting of watchful waiting for comorbid patients and small tumors, that we now have considered surveillance as a first-line strategy, even for malignant tumors. And in particular, we advocated for those less than 2 centimeters. Similarly, the American Urologic Association in their updated guideline also advocated for surveillance as a reasonable strategy for tumors less than 2 centimeters. Again, though, they did look at patient-related and tumor-related factors and often would suggest this more for those at higher risk and not necessarily a broad adoption of surveillance for all patients. So, active surveillance for small renal masses is a strategy that has become mainstream. The adoption is slow and low, but I feel the direction is in terms of growth. And we need to consider the host and the tumor. And so there are some predictive models, some of them better than others, and I'm only sharing these with you so that you know they're available to you. We've also learned that many patients treated with small kidney tumors with comorbidities are likely to die from other causes. This is one nomogram, sorry, that evaluates overall survival, competing risks of death. But let's go back to the tumor where we know that there's different histologies and these harbor different metastatic potential. Location, location, location is also relevant in small renal masses. If a tumor is central and only amenable to partial nephrectomy and or radical nephrectomy, you may survey this patient differently than one that has a tumor which is more ideally located for ablation, and you would reassess that patient as it approached 3 centimeters. So what are the evolving principles of safe surveillance? I recommend the following strategy. Quarterly imaging in the first 1 to 2 years. After that, I would do imaging twice a year for years 2 to 5 and yearly thereafter, particularly for slow growing or stable lesions. Do not rely on ultrasound alone. It is important to use axial imaging at least once a year. Chest imaging at baseline and annually, and then less frequent, is also important since the lung is the #1 risk for a metastatic deposit. So in conclusion, active surveillance should be the initial management strategy for all tumors less than 1 centimeter, most of those less than 2 centimeters, and many of those 2 to 4 centimeters. Renal tumor biopsy in most patients can direct care, and at a minimum should be considered for tumors greater than 3 centimeters when planning treatment. Papillary type 1 tumors have the most favorable prognosis, and metastatic potential is greatest with clear cell renal cell carcinoma and papillary type 2. Histology and growth rates are the current measures to direct intervention, but obviously prospective trials with meaningful and measurable endpoints are needed. Thank you.